The direction we need to go, what I like them to do when the patient is doing this, can you bend your knees up? Ben? Yeah, so when I do my thrust, my force should be in this direction, almost towards his knee, probably towards his mid-thigh. Okay, that's my force direction. If I'm on the right side, it's towards the mid-thigh of the opposite leg. Okay, this one's really a lot better with the high-low table because you're gonna see if I'm gonna make that force, I've really got to get underneath him to make that force. Okay, when do we do this? When do we think this may be indicated? The first rib. First off, do you know what a thrust technique does? What we think is happening when we're doing a thrust technique?
Going past the available range to really break up all of the stuff that could be there. Just so like the mobilization goes up to a thrust which goes past the available range of the capsule.
So we think we're breaking up the capsule even more? Is that what you guys think?
It's like a quick stretch of the capsule.
Okay. So that quick stretch, what effect does it have?
Inhibits muscle and decreases pain.
Is that like trying to get the mechanoreceptors?
Yes.
Yeah.
Yes. So another thing that's similar to this is oscillations. When we do oscillations, what we're doing is we're trying to activate some of those mechanoreceptors. They're going to travel faster than pain and give you some relief. The thing that's better with this, if you're efficient with this, is you can do one thrust in that 30 seconds or whatever it takes for you to set up and do the thrust. You can get the results that you could get in probably 10 minutes of doing oscillations. Okay, so it's just quicker. You just get it done. You go in there, you do the thrust. It gets rid of the muscle guarding. So it does. We do go, I guess, past that in range is the theory. But we're not, with this one, we're not going to do this if we think the issue is that they have a tight joint capsule. That's not what we're doing at all. What we're doing is they've got muscle guarding. What it does is it activates mechanoreceptors, and it activates them a lot quicker. Okay, it's almost like a reset button on those muscles if you do it correctly. It activates those mechanoreceptors, and it causes those muscles that are guarding to relax. Okay, that's whenever you do a thrust. That's what you're doing, okay? So again, I'm not getting this first rib and saying, oh, I think that the first rib, I think that the joint is tight, okay? I think that it's tight. I think that we need to really, really quickly stretch out that joint capsule because that's not the way it works, okay? And what we know about tissues and the way they work, especially the joint, is the quicker that you put pressure on it, okay, so I put a high velocity, low amplitude force on it, it's really stronger, okay, those tissues get stronger. The faster you put a force through it, the stronger it is, okay, whereas if you put a force slowly, like we do when we stretch the joint, and that's what we're doing, we're getting it in that position, we're holding it for 15 to 30 seconds, that's when it's weakest, that's when we can really stretch out the tissue, okay? So doing this, it's important to know that your reason for doing a thrust is to activate mechanoreceptors and to decrease muscle guarding, okay? So knowing that and knowing the anatomy of the first rib, what do you think, what may be an impairment that he would have that would lead me to doing a first rib thrust? So guarding of the scalenes, that's a big one. And really, I don't know why, but this one, a lot of times they have upper trap guarding, it works. I'm not sure why. Levator, sometimes it works with that. So those are some reasons that you would do it, not necessarily that we determine that joint is actually tight. Yeah.
So sometimes I think too is you're not sure. So is it muscle guarding or is it a tight joint? So then you do a thrust and maybe your guarding changes, gets better, but then the joint still feels restricted. And so then you've answered one of your questions. You know that you've done a quick thrust. Now you know, hey, my muscles are less guarded, but yet this joint still feels restricted. So maybe you need to do both. Maybe you need to do a thrust for muscle guarding and that pain inhibition, and then you need to address some joint restrictions. So it's a nice way to sort of help you sort of tease out what you're dealing with.
Yeah, and the way that she uses it is the right way to use it, and it also shows that it's safe. It's completely safe to do a thrust. I mean, if he had high-level osteoporosis, 85-year-old that has osteoporosis, has a lot of broken bones, compression fractures, I wouldn't do any thrust, okay? But as long as, like Ben, I mean, there is no contraindication at all to this. And like we said, it's almost more safe than if I would do a prolonged stretch because his tissues are stronger when I do a high-velocity, low-amplitude thrust, okay? So it's very, very safe. And the way that Sarah was saying that she uses it is, let's use it as a test because you can, because there's nothing unsafe about that. And especially when we're talking about the first rib, and when you get to the upper cervical, because we talked about that C1 on C2, there are some things you want to stay away from there. When we talk about the neck, and we talk about the thoracic, the lumbar, the SI, very, very safe techniques. Okay? So, because a lot of times it's the scalenes that are guarded, one of the things we want to do is put those on slack. Okay? So the way we do it with him is I side bend him and rotate him slightly to the right. Okay? I go in and I find his first rib, and sometimes with this you have to push that upper trap down and out of the way to find it. Okay? So then I find the position of his first rib, and it's right there. Is that okay, Ben? Okay. So the way I set this up, any thrust technique that I do, is I'm going to tell him what I'm doing, okay? And then when I actually do it, I tell him to take a deep breath in, I tell him to take a deep breath out, and as he's exhaling, I want him to relax, and as he starts to exhale, I take up the slack, and then give him the thrust, okay? Something that's important for that is I don't want to get here and take up so much slack that I don't have anything left, okay? Then I can't thrust. I want to take up enough slack to where I do have enough, and I can give it a quick thrust, okay? With this one, remember what I'm aiming at is like I'm thinking of I'm going to push him towards the middle of his left thigh. Okay? So sometimes too, especially if they seem a little nervous about it, I'll tell them what I'm going to do. Okay, so what we're going to do, you're going to take a deep breath in, you'll take a deep breath out, and you're going to relax as you exhale. What I'll do is I'll set you up in the position. I'm not going to do the thrust this first time. Okay? But what it'll be, go ahead and take that deep breath in, and then out. And then as you're relaxing, I'm going to take up the slack to here, and then all I'm going to do is give you a quick push after that. Okay? Hold on. Hold on. Okay, deep breath in, and then out, and just relax, relax, relax. Good.
Am I alive?
He's alive.
Still have
Okay.
control of your bowel bladder?
Yeah. So again, this is another one you just have to work on. The speed, your speeds are either going to be, most of you will be too slow. Some of you will have to say, hey, settle down, you're pushing a little too hard. That'll be one or two people, but for the most part, you'll get there. Jerry, good fun. But what you want to think about is you get to that end range, you want to have a little left, and it's just like a quick burst. Okay, you're going, it's high velocity, it's low amplitude, so I don't want to see people here and, the whole bed treatment table turning. That would be high amplitude. It's high velocity, low amplitude. Yep. So I'm not going to take you through all that, Ben. But hold on. Okay, deep breath in and out. Just relax. These beds aren't, or these treatment tables aren't great. What's that?
I was asking Ryan before, so it's
I don't know.
I'm trying to feel just like that. But I do.
Real quick, guys, when it gets closer to when we get to the days that we're doing the thrust days, we're going to be going over mechanisms of action and indications, contraindications more specifically. So it kind of seems like, well, okay, now we know osteoporosis, we probably shouldn't be doing that, but there are other ones out there that you're not going to do, and we're going to teach them to you. It's just going to come a little bit later in the course, but as we're going through the body regions until we get up to that day, We're going to teach you some of the techniques, not all of them, and then when we get to that thrust day, we'll be teaching you a lot more different ones, having you practice more. So there's a lot more information coming on these techniques and why they work and how they work and how to make the right decision to choose, okay, this is the person I want to do it on, and this is the type of person I probably don't want to do them on, you know, kind of help guide your clinical decision making there a little bit.
So this is one of your slides. You can look at this as far as, you know, doing the manipulation screening. One, you may do a vertebral artery insufficiency screen, okay? Oh shoot, you told them at the beginning of the class, what are the 5 Ds and the
Yeah.
the
Yep.
3 Ns? Dizziness, dysphagia,
Dysarthria.
Diplopia.
okay. And then the Ns,
Nausea, nystagmus, and what's the last name?
it's in the beginning, it's in like the first 2.
Numbness and tingling, I think it is. I think it's just numbness and tingling.
Numbness and tingling,
Yeah, I think it's numbness.
Um,
Any neurologic signs.
Ligamentous testing, that may be something else you do. And remember, we use this as kind of a screening tool early in your examination where you're doing that ligamentous testing just to make sure that the ligaments